Good afternoon. I'm going to attempt to describe a complex subject which is ill understood by many, but it is of a common occurrence, and it's very important to present it in an organized, understandable, simplistic manner so that we could apply the learned knowledge in our patient care. So to do that, I'm now going to take help of my PowerPoint presentation. And of course, you can see my microscopic picture on the screen. So how does one describe Parkinson's or Parkinsonian syndrome? And suffice it to say that it's a chronic and progressive neurodegenerative disease, the etiology of which is still unknown, but there are many foci of attention which lead us to a causative relationship with certain organic brain disorders and also with the symptoms of Parkinsonian syndrome. So the disease leads to loss of dopamine-containing cells of the substantia nigra of the midbrain, as a result of which basal ganglia functions are affected, leading on to a movement disorder with classical Parkinsonian motor symptoms, which we'll describe in detail further on. Parkinson's disease is a form of symptomatic Parkinsonian syndrome, but it is usually not symptomatic until at least 50% of the dopaminergic cell activity has been lost, which means that half of the patients who have Parkinson's disease may not have any noticeable symptoms. And this is why telltale signs and symptoms must be looked for in vulnerable patients. So in order to understand Parkinson's disease, we need to understand the pathological basis of symptoms. The crux of the matter is with L-DOPA, which is 1,2,3,4-dihydroxyphenylalanine, L-DOPA. And whereas Parkinson's disease is a form of Parkinsonian syndrome, we can see that the syndrome is caused by neurodegeneration. And if neurodegenerative features are present, then it would be classical Parkinson's disease or multisystem atrophy. If there are vascular lesions causing ischemic necrosis of the midbrain, then they would be similar but not quite the same features. Sometimes Parkinsonian syndrome can be caused by poisoning, such as from manganese, carbon monoxide, carbon dioxide, some antipsychotic medication, and after encephalopathy caused by flu virus. The lesion of Parkinson's disease is a neuromediator deficiency affecting the noradrenergic nuclei and also some other important nuclei such as the vagus, serotonergic nucleus, Edinger-Westphal nucleus, and that there is haphazard involvement of dopamine deficiency, and sometimes dopaminergic cell losses can be up to 30 to 90% before symptoms develop. Carlson, a Swedish scientist, got his Nobel Prize whilst researching for Parkinson's disease and L-DOPA. What has been discovered is that although it's the dopamine deficiency across the substantia nigra in the midbrain and the nuclei, If extrinsic dopamine is given, then it does not reach the specific deficient part because it does not cross blood-brain barrier. And so therefore it can't be used, even if it's extracted chemically, it cannot be used to treat Parkinson's disease. Instead, levodopa, which is a precursor of dopamine, which does cross the blood-brain barrier, is used. Whereas if levodopa is ingested, then it breaks down in the bloodstream. So levodopa is typically ingested with another medication that stops it from breaking down. This combination, carbidopa, levodopa, is used. When levodopa is taken with carbidopa, much smaller doses of levodopa can be used to produce desired effects in mitigating the motor symptoms of Parkinson's disease. Carbidopa, levodopa, the brand name of which is Sinemet, is the mainstay of treatment of Parkinson's disease and is the most effective medication available for Parkinson's disease. Now, carbidopa, levodopa improves the symptoms and mainly the motor symptoms, but it does not alter the course of Parkinson's disease. In other words, it's a progressive disease and it will keep on progressively getting worse despite adequate control of symptoms with carbidopa, levodopa, or other agents. However, it generally improves some motor symptoms such as bradykinesia, stiffness of the muscles, and also to some extent the tremors as well. There are numerous brands of this product called Sinemet, Stalevo, Entacapone, Ritari, Duopa, Parcopa, Inbrigia, and so on. Inbrigia is the newly approved inhalation formulation containing only levodopa. And obviously it is quickly absorbed from the nasal mucosa into the bloodstream, and it is used as a rescue medication. So what are the factors which can lead up to Parkinson's disease? There are environmental and genetic factors. Carbon monoxide, manganese, hard metal such as mercury, pollution in water, and also in living in gaseous environments such as close to a chemical factory. 20% of the patients have a positive family history with at least one blood-related parent. As such, it is held that it has a genetic transmission basis as well. And there are at least 24 genetic loci which have been found when studies of siblings are conducted. Some medications, such as antipsychotics, SSRI, and others, can induce Parkinsonian syndrome, cerebrovascular disease, Lewy body dementia, multisystem atrophy, and progressive supranuclear palsy can also lead to features of Parkinsonian syndrome. So these are triggers which are related in the development of Parkinson's disease. So what clinical features does one see in Parkinson's disease? There are tremors, and these would be present usually even at rest. If they involve the thumb and the finger, then the tremors seem like as if pill rolling. but tremors could be absent in 30% of the patients with established Parkinson's disease, but it is a common symptom. Rigidity of some joints leading up to even contractures is often found, and the rigidity could be very stiff, as if it would be a lead pipe type where you just cannot overcome the rigidity by manual passive movements. Or it could be cogwheel, such as like this. So there will be break of rigidity in interrupted fashion. There is difficulty in initiating movements, and these could be with hands, affecting manual dexterity. It could be affecting the facial muscles of expression. So the person has inadequate or improper facial expressions on challenges. There would be bradykinesia, which means progressive poverty of movements. And so any movement initiated can start early enough, but it slows down in its pace. So the lifting of hand can be like this. And there would be abnormal gait. And the specific characteristic is a tendency to fall backwards. And that is why a person is always trying to lean forwards. Not being able to control manual dexterity, one writes in a microscopic manner. But there can be non-motor symptoms as well as part and parcel of Parkinson's disease, such as depression, fatigue, cognitive impairment, sleep disorder, and progressive constipation. So what is the prevalence of Parkinson's disease? A clinical practice research data showed in the NHS in 2015 that at that time, there were 137,000 patients diagnosed with Parkinson's disease. So the prevalence since then has been 286.5 per 100,000. By that reckoning, there would be 17,300 new cases of Parkinson's disease diagnosed every year. If the Parkinson's disease becomes symptomatic at an older age, such as 50 to 69 years, then the prevalence speeds up. Men are more frequently affected than women. What is the prognosis of Parkinson's disease? It's a slowly progressive neurodegenerative disease, but the rate of progress is variable. It is not connected to symptom control. If older age group is involved at the onset of symptomatic Parkinson's disease, then the prognosis is worse. Also, when Parkinson's disease has been present for a long time, then not only is the prognosis reduced, but life expectancy is reduced and mortality rate increases by 70 to 89%. It does increase by 2.5 times of the biological age comparison. Parkinson's disease has a risk of developing additional dementia 2 to 5 times. So the characteristics of Parkinson's disease are that it is generally symptomatically controllable, but not curable. It is progressive, it is degenerative, it's caused by dopaminergic reduction in substantia nigra of the midbrain with corresponding increase of acetylcholine transmitters. So some of the symptoms might be due to acetylcholine excess, and such as constipation, vasomotor symptoms, and so on. 1 in 40 times it is male predominant at the age of 65. It's characterized by motor symptoms, which we have talked about already, and non-motor symptoms such as autonomic, flushing, hypotension, psychiatric, such as impulse disorder, sleep disorder, and also associated with exaggeration of pre-existing psychiatric condition, anxiety and depression. It produces sleep disorder in a sense that it can cause abrupt onset of sleep. And hence it could be a factor to consider with regard to driving license. It is associated to a high degree with dementia. We have already talked about Parkinsonian syndrome being a part of containing Parkinson's disease as its integral part, but there are other neurodegenerative diseases as well, such as multisystem atrophy, motor neuron disease. It can be caused as a post-encephalitis problem, especially after a flu virus infection. Recurrent head injury is also another cause. Certain drugs, such as antipsychotics, SSRI, are also associated with higher incidence of Parkinson's disease. Toxins, particularly venoms, manganese-containing substances, and hydrocephalus from any cause can induce dopaminergic deficiency of the midbrain. So what are the diagnostic features? So you can see bradykinesia, and the hypokinesia is visible with manual dexterity, reduced facial expressions, a faltering, fascinating gait where a person tries to prevent falling backwards, stiffness and rigidity, rest, intention tremors, which improve with mental diversion, pill rolling tremors. But such motor symptoms may be absent in 30% of cases. We have talked about gait imbalance, and non-motor symptoms could be cognitive impairment, reduced smell, interrupted and sudden sleep, and constipation. So how does one differentiate it? So drug-induced toxicity causing Parkinsonian syndrome can be caused by first-generation antipsychotics after 10 weeks of use, such as with flufenazine, trifluperazine, triflufenazine, haloperidol, chlorpromazine, and flupentixol. These are all drugs which have been used in the past for severe depressive psychosis. It can also be caused by second-generation antipsychotics such as amisulpride, aripiprazole, clozapine, olanzapine, quetiapine, and risperidone. Parkinsonian syndrome can also be induced by antiemetic of various kinds, antidepressants, particularly SSRI and SNRI. calcium channel blockers, amiodarone, methyl dopa, sodium valproate, pethidine, and lithium. They can also be induced by, that is, Parkinsonian syndrome can be induced by recurrent head injury, and they are to be differentially diagnosed from essential tremor, which is usually bilateral, symmetrical, and present in stress. Dystonic tremor, hyperthyroidism, and cerebellar disorders. So how does one investigate it? A clinical neurological examination would show extrapyramidal signs, conscious level, attention span, memory tests. If there is a history of fits or collapse, there should be witness description, routine blood examinations to exclude other problems, ECG to prevent, to assess for cardioembolism, imaging studies such as MRI are the baselines of seeing features of neurodegeneration, and its activity can be assessed further with PET scan. There is little role of EEG or any other neurological assessment other than assessment of the functional deficits. So how does one treat patients who have got a diagnosis of Parkinson's disease? You could use dopaminergic receptor agonists or levodopa itself, or monoamine MAO-B, monoamine oxidase inhibitors of a B type, or COMT inhibitors. One could also treat patients with deep brain stimulation. We will discuss a few of these individually. So, of the dopaminergic receptor agonists, bromocriptine has been around. And it stimulates the dopamine receptors. The optimum dose is 10 to 30 milligram per day. And it's used as 1 to 1.25 milligram daily for 1 week at night time, then increase to 2 to 2.5 milligram twice a day for 1 week, and then 2.5 milligram 3 times a day for 1 week. And then increasing gradually to 10 to 30 milligram per day. Bromocriptine is also used for hyperprolactinemia as well. The side effects include nausea, vomiting, hallucination, and abnormal movements. There would also be fibrotic reactions in pericardium, retroperitoneal, and pulmonary linings. There is also reported impulse disorder and excessive daytime sleep. It's contraindicated in coronary artery disease, hypertension, fits, and when there are visual disorders. Other dopaminergic receptor agonists include amantadine, apomorphine, cabergoline, pramipixole, ropinirole, rotigotine. And rotigotine can be used as a transdermal patch of 2 milligram per 24 hours and then increased every week. Side effects include agitation, angioedema, confusion, and diplopia. Monoamine oxidase beta inhibitors can also be used for controlling symptoms. And these are rasagiline, selagiline, safinamide. And I have listed in this PowerPoint the trade name of these medications and the suggested dosages with side effects. Another group of medications used belong to catechol O methyltransferase COMT inhibitors. And the common in this group have been entacapone, opicapone. And if there is an acute need for controlling life-threatening symptoms, which have happened repetitively, then deep brain stimulation can be tried with battery-powered generators after implanting electrodes in the affected part of the brain. So the implications of Parkinson's disease would be commonly seen in respect of driver's license. Both in Group A and Group B holders of driver's license, DVLA needs to be informed of the diagnosis and the date of Parkinson's disease, and a medical questionnaire would be sent to the GP to confirm medication and to show stability. Most patients at an early part of Parkinson's disease may be considered fit to drive if they feel that they are safe and if there are not too many variables in terms of motor symptoms, and if it has not caused any disability, such as in emergency control of a vehicle. Safety at work additionally includes conveniences such as the chair to sit on, the amount of material to carry, not to undertake hazardous activities like operating equipment which is safety related. Patients should also be screened for inherent depression. Depressive disorder is very much associated with Parkinson's disease, and it is usually of a significant nature. So various screening tools should be applied, such as HAD, PHQ-9, and other tools of depression. Long-term management of a patient diagnosed with Parkinson's disease must be liaised with the Parkinson's specialist, who will arrange for patient to be educated with leaflets, with online information, with contacting various support groups, and also putting in provisions for a Parkinson's disease clinical nurse specialist who is accessible to patients for quick short-term advice. And in addition, patients should remain on perpetual follow-up of these specialists. So once again, what I'd like to summarize is that it is a chronic neurodegenerative progressive disease of unknown etiology characterized by loss of dopaminergic cells with reduced dopamine and corresponding increase of acetylcholine neurotransmitters in the region of midbrain and substantia nigra, the effects of which lead on to movement disorders of various kinds. And so, in addition to motor symptoms, there would be non-motor symptoms as well. So I hope that you've been able to follow what I have been trying to relate, and I hope that you have enjoyed the presentation. Thank you for joining. Thank you. Bye-bye.